Welcome everyone to the CHEPS seminar this week. You get to hear from me this time. So this paper you're going to hear about today is joint with my colleagues Dan Reese and Laura Argus at the University of Colorado, Denver, with Dval Dave at Bentley University and the NBER, and a former master's student in our economics program here at SDSU, Josh Latshaw. And in this paper, we're looking at the effects of two policy interventions that are designed to tackle the opioid crisis: naloxone access laws and Good Samaritan laws. And each of these types of laws involves a third party providing assistance that can potentially save a life of somebody who is overdosing from illicit substances, including opioids. And that's why we borrow from the old Beatles song and call it, "With a little help from my friends, maybe you'll get by." So for those of you who aren't aware, since the early 2000s, the number of drug overdoses in the United States has skyrocketed. It's more than doubled. And this doubling of drug overdose deaths has been driven by opioids, that is prescription painkillers and heroin. The Centers for Disease Control and Prevention has declared that the current overdose epidemic is the worst that this country has faced in its history. And to give some idea of the magnitude to you, there have been nearly 200,000 opioid-related overdose deaths in the United States since the year 2000. That's more than 3 times the number of men who died during the Vietnam War. So a lot of people are very angry about this and wanting to understand, how did we get here? There's not a straight line to how we got here, but I want to give you the main arguments and main stories about how we got here. Most believe it's due to a so-called overprescription of opioids to treat pain. And I'll talk a little bit more about this. It's some combination of physicians thinking that they were helping, well-meaning physicians prescribing pain medication, not understanding the addictive properties of what they were prescribing. A combination of pharmaceutical companies and physicians pursuing self-interest in their profit motives, again, maybe with what they thought were serving consumers' interests. And deregulation efforts that made it more difficult for the Drug Enforcement Agency, the DEA, to combat the so-called dumping of opioid pills on the market, big increases in supply of opioid pills. Another reason that's been offered for how we got here is a resurgence of heroin in the late 2000s and early 2010s. But as I'll talk about, some of that resurgence of heroin may be an unintended consequence of government's efforts to combat prescription painkillers. So here's a little ancient and modern history about opiums. That's a picture of an opium plant. All right. So opium's been around forever. It's been collected since at least 1500 BC. It's been used as part of religious traditions. But there have been important medical reasons that opium has been used, and it's often again to treat injuries and chronic pain. So how do opioids work? So this is my one sort of attempt. I'm not a chemist. I'm not a doctor. I'll give you a flavor of how they work. So opioids act on what are called opioid receptors. You have 3 opioid receptors, mu, delta, and gamma, in our brain and spinal cord. And opioids attach to these receptors, and essentially that reduces the intensity of pain, or at least the signal of pain that affects your perception of your feeling pain. So this is why these have been prescribed as painkillers or to treat injuries. So another consequence of this attachment to receptors is a slowing of breathing function. The drug has tranquilizing properties, and when breathing function slows enough, this is when you may get an overdose and maybe a death. Opium also reaches sensors in the brain that cause euphoria, so this is the high that leads to potentially addictive properties. So there are what are called naturally occurring opiates that come from the opioid plant. Morphine and codeine and heroin is a sort of byproduct of it. And then, I should say more recently, we have synthetic and semi-synthetic opioids, which are chemically created drugs that act like opioids. So morphine and codeine, the sort of natural opiates, have been used for a long time to treat injuries and chronic pain. So for instance, during the American Civil War, 500,000 opium pills were distributed among soldiers. In fact, the opium was called God's own medicine. And in the 19th century, it was really common for doctors to prescribe opiates for women's menstrual pain. And in fact, if you look during the 19th century, the biggest share of opium addicts were women. So the addictive properties of morphine, codeine, and heroin have been known for a long time, and countries have been taking regulatory action to try to curb the abuse of opium, getting in ancient China. But the addictive properties of synthetic and semi-synthetic opioids was less clear. So when I'm talking about the synthetic and semi-synthetic sort of chemically created opioids, I'm talking about drugs like Demerol, fentanyl, methadone, oxycodone, taking the form Oxycontin, and Percocet, and hydrocodone, commonly known as Vicodin. So these got really popular prescribed prescription pain relievers during the 1990s and through the 2000s. So why didn't we understand that semi-synthetic and synthetic opioids had the same sort of addictive properties as the natural opiates? And how much did we know? Well, one important reason to think maybe people were sort of misinformed about their addictive properties dates back to a really famous article that appeared in the New England Journal of Medicine in 1980. So could this have been a catalyst? So this was a very famous study now by Porter and Jick in the 1980 New England Journal of Medicine, in which they're describing a study in which they're looking at hospital patients who are prescribed with narcotics, opioids largely, and seeing whether addiction develops among those who are treated under doctor's care. And so they find, although about 12,000 patients received some narcotic, only 4 cases of reasonably documented addiction in patients who had no history of addiction. And here's the key line in bold: we conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. This work has been cited hundreds and hundreds and thousands of times out there, and doctors believed it. The New England Journal of Medicine is very sort of worried about this, and just this summer, in June, they issued this editor's note in response to that 1980 piece. So they write that we believe that this citation pattern from that article contributed to the North American opioid crisis by helping to shape a narrative that allayed prescribers' concerns about the risk of addiction associated with long-term opioid therapy. So they're trying to get the word out that. So they're not arguing Porter and Jick are wrong. Actually, they're arguing that that outpatient prescription of opioids looks a lot different than prescription of these narcotics while you're in hospital under a doctor's care. So that's part of so Porter and Jick, at least one of them, are still around and trying to sort of defend their work. There wasn't anything, they weren't sort of paid off by the pharmaceutical industries or something like that. For all we know, it was pretty credible work. But it's definitely been cited in such a way that led people to believe, hey, don't worry about it. There aren't going to be these unintended addictive properties of these synthetics and semi-synthetics. So pharmaceutical companies produced, doctors prescribed synthetic opioid treatment for chronic pain among outpatient populations. And then what we saw was a recreational use of these synthetic opioids, which represented a very low-cost alternative to heroin, began to rise, and we saw big spillovers into the black market. And we saw expansion of so-called pill mills, or pill dumping, by pharmaceutical companies to retail pharmacies in certain communities, and we saw a lot of prescribing going on, and some doctor shopping on the part of consumers as well. So what do I mean by sort of a pill mill or sort of pill dumping? So here's an example from West Virginia. Brad Humphreys, an economist at West Virginia University, he edits the Contemporary Economic Policy. He does a lot of work on the opioid problem in Appalachia and in particular in West Virginia. So he has talked about Mingo County, West Virginia, where so this is a single pharmacy in a town, Williamson, with a population under 3,000, received 258,000 hydrocodone pills in 1 month from one pharmaceutical company based in Ohio, Miami Lucan, and that's more than 10 times the usual delivery of these synthetic narcotics to a pharmacy in West Virginia. So this is a quote from the DEA liking pharmaceutical companies, and they have some regulators at the DEA have likened pharmaceutical companies' actions during this time to that of a drug cartel. Like sharks circling their prey, these multi-billion-dollar companies have been descending upon Appalachia to profit off of people's addiction. I mean, on the other hand, people could argue that they're getting into pills to those who may need the most to fight chronic pain, but this is potentially one of the profit motives that companies may have to get pills in communities where there is addiction. So for those of you who didn't see, this is a nice week to be giving this talk. A lot of news on opioids sort of broke in the last week. So this past weekend, there was an investigative story in the Washington Post. The title of the piece, if you haven't seen it, look it up. It's really interesting, called the drug industry's triumph over the DEA, basically detailing how some regulatory powers of the DEA were diminished with regard to opioids. So it details a piece of legislation that was championed by Republican Congressman Tom Marino from Pennsylvania, who argued that the legal standard that the DEA was being held to basically issue sort of cease and desist orders to pharmaceutical companies who might be dumping pills. The legal standard that the government was being held to was they had to prove that the company was an imminent danger to the population. And Marino and a lot of congressmen argued that imminent danger wasn't well defined in the law. So said, let's define what that legal standard we should hold the DEA to is. And so what was written into a new piece of legislation, and this investigative piece sort of tracks this legislation over the years, how it eventually became law, sort of defined this legal standard. And it is now, in order for the DEA to file a lawsuit against a pill mill, they've got to prove that they've got to show evidence of a significant and persistent risk of death or serious bodily harm that is more likely than not to occur. So that's been interpreted as actually raising the bar that the DEA is being held to in order to file these sort of suspension orders or cease and desist orders. And as a result, immediate suspension orders declined from about 65 in fiscal year 2011 down to about 8 in fiscal year 2015. So, some argue, well, you're letting the drug cartels dump their pills, doing the most harm. The counter argument was you're deregulating, allowing it to be easier for these pills to get to those who need them, and stopping the government from interfering with the market. Go ahead.
Don't you think it wasn't the change in the law itself, but the change in the direction given to the DEA by a higher authority? The way you described it there, that would seem like would give them plenty of authority to go after the kind of cases that you had in West Virginia.
Yeah, I mean, the DEA for a while so this article also sort of talks about the revolving door of regulators at the DEA and working for pharmaceutical companies, and the sort of the increasingly close-knit relationship between those lobbyists turned regulators and back and forth. So that clearly had sort of something to do with it. But there were those who were within the DEA. It reads like you could see a movie being made of this very easily. So it's sort of like a crusty old DEA regulator who's been there for 30 years, but has, who's on the right side of things with trying to go after the drug companies, but has no political skills, whatsoever, and starts exclaiming crazy, politically incorrect things sort of on during a phone call, calling pharmaceutical companies like drug cartel, that kind of thing. And so he became sort of politically marginalized, and the forces of pharmaceutical companies and their campaign contributions sort of dominated what the erstwhile regulators wanted. So there's a lot more to the story than, I agree, than just the sort of changing of the standard, but it certainly seemed, yeah, so whether this reduction in suspension orders was driven by this change in language or by other forces that were putting pressure on the DEA not to take these actions, that's possible too, yeah.
Yeah, that led to Don Marino removing his name for consideration, being a Drug Czar.
That's right, so that's where we are. Two days ago, Marino was nominated by President Trump to be the new Drug Czar. And clearly, in part, due to this Washington Post story, he's out. He's removed himself from consideration for Drug Czar. And Trump has announced that he's going to declare a national emergency next week over the opioid crisis to show how serious he is about it. I mean, in fairness to Marino, this change in the law was not only approved by the U.S. House of Representatives and the United States Senate, it was approved by unanimous consent by the House of Representatives. Not a single congressman or senator opposed this regulatory change, and President Obama signed it into law. Anyway, he certainly took the fall as he was the person sort of leading the legislation, and this is where we are. So aside from national emergency declarations, which might come next week, what have been the policy initiatives to try to address the opioid overdose crisis? There have been some high-profile crackdowns on these so-called pill mills, most notably in Florida in around 2012, 2013, where they actually used drug trafficking laws to go after doctors and pharmaceutical companies. They also did a better job at monitoring prescriptions and where the pills were going as part of what a number of states have adopted what are called prescription drug monitoring programs. So these are state electronic databases that allow state regulators to observe the number of prescriptions written for what drugs, what pharmacies are they going to, what doctors are writing them, who's getting them. This increased monitoring by the state is argued to be one way that you can put pressure to reduce overprescribing of prescription painkillers. And on the effects of prescription drug monitoring programs, that's where most economists who have studied the opioid crisis have focused. And I'll talk to you about what those studies have found. But people are wondering, is there a silver bullet that could sort of solve this epidemic? There usually isn't a silver bullet, but could there be a miracle drug? So I want to talk to you about naloxone or Narcan. So Narcan, so again, I'll play chemist and doctor a little bit. So naloxone is what's called an opioid antagonist. And what it can do is to temporarily block or reverse the effects of an opioid overdose. So the way it works is, as I said, an overdose is caused from opioids attaching to your brain receptors, causing breathing to slow to such a rate that you overdose, stop breathing, and die. What naloxone does when administered, it can essentially prevent the opioids from attaching to these receptors, restart breathing, and bring you back from the overdose. Naloxone as a drug can be administered via injection, either from someone else or, as I'll talk about, self-injected, and it can also be administered via nasal spray. So it can potentially it can permanently reverse an overdose. So you can get a dose of naloxone of between usually about 1/2 to 2 milligrams, and it can reverse the effect of, say, a heroin overdose or an overdose due to a prescription painkiller, and it can do that. And there's once it's removed the opioids from the receptors, if there's not lots of opioids remaining in your system, you're fine. I mean, physically, and you maybe don't have to go get medical care. I mean, there may be some underlying root cause reasons why you need to go get medical care, but not for that particular overdose. If there are enough opioids that remain in your system, then this overdose could be temporarily reversed, but give you time to get to a hospital to get medical attention or for another dose of naloxone to be administered. So Naloxone's been around a while. So it was patented in 1961. New York scientists were searching actually for drugs that could treat side effects from chronic opioid use, largely constipation. And naloxone was one of the drugs they were experimenting with. It was approved by the FDA in 1971 for use as an opioid antagonist. So it can be really easily administered. Studies have looked at how effective laypersons versus medical professionals are in administering naloxone to see whether rates of overturning overdoses are higher if a doctor is doing. No, rates of overturning overdoses are comparable among laypersons and doctors. So that's a nice property of it as well. Is naloxone addictive? Does it gain the same euphoria? No. So there are no addictive properties to naloxone. If anything, it's going to stop whatever euphoria you might be feeling from taking the opioid. So no addictive properties. And then the big question, what happens if you're not overdosing from opioids? You're overdosing from something else. Or you're just sleeping. You're not overdosing at all. There's nothing wrong with you. And somebody gives you a dose of naloxone. Basically, what if you're wrong in your diagnosis of this person overdosing due to opioid? Basically nothing. There are no adverse consequences that come from administration of naloxone to somebody who is not overdosing. Now, it's not going to help you if you say you're overdosing from meth. It's not going to bring you back given the chemical properties, but it's not going to do additional harm either. There's a few small side effects, but this for the same any drug. There could be some, in minor cases, allergic reactions, or if you got major heart trouble, but basically nothing. So this led, as I was describing naloxone to sort of a colleague, said, man, this sounds sort of miracle druggish. I mean, there's no real side effects. You can be wrong about administering it, and it's bringing people back to life. My God. So here are the three most common forms of naloxone. So we've got a form in nasal spray here on the top left. The bottom left is the injectable kind of naloxone, usually with somebody else injecting it for you. And Evzio here is with a horrific sort of photo going with the ad for it. This is the self-injecting naloxone that someone could inject themselves with without the syringe. So a natural question is, well, why has this has been around? This has existed since the 60s. The FDA approved in the late 70s, in the early 70s. Where has it been? Why has the supply of naloxone been so low? Well, because it's true. Prior to the mid-1990s, the only place you could find naloxone was basically in hospitals. So if you made it there, then doctors might administer naloxone, and they thought you were overdosing from opioids. Doctors might administer it. But physicians wouldn't prescribe it, law enforcement wouldn't carry it, laypersons wouldn't administer it, and those closest to those at risk of overdose could not obtain it and wouldn't carry it. So why? Several reasons for this. First was doctors weren't prescribing this at all for fear of kind of moral hazard sort of concerns, that this was going to, by lowering the cost of risky use of illicit substances, you're going to see more of it and maybe more overdoses. And more importantly than that moral hazard kind of argument, they were concerned about being held civilly and maybe criminally liable. Because the law didn't protect them. Because the law didn't protect them. The laws actually we're going to look at do provide some protection for physicians and laypersons who administer it. But it was fear of being sued and perhaps being held criminally liable. So those are the biggest reasons that have been offered by those in the medical profession why they weren't offering it. Yep.
Why would they be more afraid of being sued for prescribing this naloxone than for prescribing the opioids in the first place? Why?
Well, a few things. First, again, it was sort of general practice and general wisdom that these didn't have these addictive properties. That was the sort of state of knowledge at the time when doctors were making those decisions. But prescribing drugs that could generate incentives for their patients to potentially do more drugs was what doctors saw as a bigger problem. Yeah.
So you'll probably get to this, but
sure.
you look at opioid-related mortality
Yep.
in response to these laws.
Yeah.
You actually look at usage too as sort of a...
Yeah, a little bit. Yep, yep, that's right. For sort of for the moral hazard, for the moral hazard story. Yeah.
Do you find
Yeah.
any significant increase in opioid usage following the adoption of these laws?
To preview, no. Yeah, that's right. So the law I'm going to study largely as part of this paper are what are called naloxone access laws. So basically in an effort to increase the supply of naloxone available to those at risk for overdose, New Mexico, I don't know too many things New Mexico is a trailblazer at, but New Mexico is a trailblazer in naloxone. They passed the first naloxone access law in 2001, and under this law, trained responders, in this case police and firemen, were authorized to administer an opioid antagonist such as naloxone if they believed that somebody was experiencing a drug overdose and would be free of civil and criminal liability. So, and that's the second part of the statute. Any person who administers an opioid antagonist, not only emergency responders, anyone else, won't be subject to civil liability or criminal prosecution as a result of the administration of the drug. And since New Mexico started, 44 additional states plus DC have followed with some form of naloxone access law. So there's some differences across the different naloxone access laws that states have adopted. Some naloxone access laws allow doctors to issue what are called third-party prescriptions. So for example, offering prescriptions to those who know, family members, friends of those at high risk for overdose, so not just the patient. Others allow standing orders that allow greater freedom to pharmacists in allowing the drug to be given out. In August, this summer, New Mexico again became a trailblazer. So New Mexico became the first state that requires police to carry naloxone. In further recognition of the role that third-party laypersons could make in sort of saving lives, and this goes more broadly than opioid-related overdoses, 34 states in the district have adopted some form of Good Samaritan law. So Good Samaritan laws are going to, if you're basically doing some illicit substance with someone else, and that person starts overdosing in your presence, and you in good faith call for medical attention to try to save that person's life, then you won't be held criminally liable for possession. There is plenty of I'll talk about this in a minute, but there's plenty of qualitative evidence to suggest that people do not call 911 because of fears of arrest when they are doing drugs with somebody who is overdosing. So by conferring immunity for possession of controlled substances, the argument is that you're going to be increasing the likelihood that folks get the emergency care they need. Yeah, go ahead.
Well, so just as a general thing on Good Samaritan law,
Sure.
it's kind of the impact of the Good Samaritan law requires kind of a forward-thinking, rational individual. If you're going to have some kind of effect of any Good Samaritan law, with corresponds to drug use, right? So,
Oh, I'm sorry, for the moral hazard part of it, or for the...
I'm just thinking about just in general, if
Well, you
this
have
is
to
going to reduce like drinking deaths in college or something, right?
Right. Well, you got to know about the law.
You have to know about the law.
Yeah.
And you have to be in kind of your right mind.
Right, so ex ante.
I'm curious, in the other literature on Good Samaritan laws, have they found that that these can be effective in these different settings, or that when a law changes, that it becomes common knowledge fairly quickly among?
Let me get back to this in a slide or two, and you can and we'll talk about it again. Yeah. No, it's a very good point about both knowledge of the law and sort of ex ante prior to you're out of it, sort of knowing what you might do in that sort of state of the world. Almost, yeah, I guess you could think of a real form of sort of rational addiction, or yeah. All right. Oh. Yeah, okay. So we've sort of already alluded to some of maybe the unintended consequences of naloxone access laws and Good Samaritan laws, right? By reducing the expected costs of illicit drug use, they could generate increases in drug use, and if that increase in drug use is big enough, maybe they could increase mortality. If knowing naloxone is available is going to, it's going to save your life, so we can have a grand old time now. So that's one. Second, while NALs provide those who are overdosing maybe more time if their overdose is reversed to get emergency medical care or just other medical care to treat some of the underlying causes of their possible addiction that led them to that overdose, most don't go get medical attention. They use the naloxone as a substitute for getting other medical care. That could be a problem if you think getting emergency medical care might be a better long-run way to treat your sort of underlying health condition. So that's been a concern too. There also could be spillover effects to other drugs. This could go in a positive or negative way depending on whether the drug is a complement or substitute for heroin or prescription painkillers, and thinking about if there are other adverse health effects of related drugs. So in general, the theoretical effects of the theoretical predictions on the effects of Good Samaritan laws and naloxone access laws tend to go in the same direction, except for hospitalizations, where we would imagine Good Samaritan law should unambiguously increase hospitalizations. NALs, the effect could be sort of ambiguous depending on if they're, as I said, view hospital care as a substitute or complement. But we're actually not going to look at hospitalizations in this paper, unfortunately. One of the things you're not going to see. Go ahead.
So you talked a little bit about how kind of who can access the naloxone varies across states, so whether it's policemen and firefighters or whether it's the individuals who might be drug users themselves.
Yeah.
Are you able to sort of characterize states based on?
A little bit. So we'll look at some policy heterogeneity, and I'll tell you the dimensions we can and what we found when we did. Yeah.
So I think definitely if the patient could access the naloxone themselves,
yes,
be prepared, that would make a big difference compared to this.
Agreed, because even when, the New Mexico laws is sort of interesting, mandatory, but there have been, they're, by the way, the first state to mandate the police carry. There have been local communities that have done this. I think Quincy, Massachusetts, their local police force were among the first to agree to carry. But even with states that allow or prevent criminal or civil prosecution to happen, some police departments just have not been willing to carry, and not on principled or moral hazard kind of grounds, but they say they have lots of stuff they have to carry around all the time. There are expiration dates on the drugs. This is one more administrative cost for them, and they've said no. So there's a Huffington Post piece, I remember, sort of expose about local police departments that were saying why they weren't all carrying. So I agree that heterogeneity in the type of NAL may be important, and we'll show you where we think it bites most.
Along those lines, from thinking back to my EMT days, which was a long time ago, but it was my understanding that Narcan is something that's basically all paramedics have with them at all times. And I don't know if that's a Colorado state thing or if is that varies state to state. Presumably the marginal impact of giving Narcan to police officers and firefighters has got to be pretty small, because the only gap you have there is just the response time between when the police officer arrives and the ambulance arrives.
That's been another one of the arguments of police about arguing that the marginal gain is so small and the cost of making us do this is so high that it's not worth it. There are some cases where we get there sooner, but most not.
Right.
So yeah.
So I wonder, and I don't. Have you looked into the laws in terms of, or is there state variation in terms of states where paramedics have standard issue Narcan versus where they don't? And
no.
In that case, you might expect to see some heterogeneous treatment effects if there is some cross-sectional differences at baseline.
No, that's a good. We certainly haven't looked yet, sort of at heterogeneous effects by sort of pre-treatment sort of characteristics of the state. We've just sort of tried to look at different types of laws about whose hands the naloxone is likely to get into, given the sets of the parameters. But that's a good. Yeah, it's a good.
I guess
good suggestion.
Probably most paramedics in most states are carrying.
Yeah.
With them, so you might not.
That's right. On that mention. Yeah, that's right. That's probably true. So by the way, if you think this moral hazard, so again, one of our master's students in the program sent me this. Now, and I think I titled the slide, now that's what I call moral hazard. So this is a story out of North Carolina. I'm not going to pretend that this is, I'm not.
The new flatliners review.
Yeah, no, precisely. The article sort of describes the rush of being brought back. So.
Is it a sure thing?
What?
Is it a sure thing that if you're overdosing that you're going to be brought back by a dose of Narcan? Like what percentage of cases don't get revived?
So it's going to depend on how it does depend on how the quantity of sort of opioids in your system and the dosage sort of that you're getting. But it's highly effective if administered quickly enough. Yeah.
This may be a question for a medical doctor.
Yeah, probably.
So once the opioids bind to the receptors, will the Narcan bump them off?
Yeah.
Or is it bumps them off?
Yeah, that's right.
So presumably, if you're at a Narcan party, even if you took just an ungodly amount of opioids, a couple people can hit you with their pens and you're good to go.
So you can OD again if there are enough opioids remaining in your system. After a time you can re-overdose if you've got too much. So we'd have to be all over you to make sure. So it's just it's going to depend on quantity of you doing. But anyway, it's out there. It's out there. So NALs and GSLs enjoy quite a lot of support, both politically in general and certainly from medical and public health groups. So the American Medical Association, U.S. Conference of Mayors, American Public Health Association, all supportive. But there are critics. So for instance, the governor of Maine, Paul LePage, recently vetoed an expansion in the state's naloxone access law, expressing concern that the laws could encourage drug use and hamper law enforcement. So despite these laws being adopted increasingly widely and the widespread support in the medical and public health communities, as well as having pretty broad political support as well, we know next to nothing about the effect of naloxone access laws and Good Samaritan laws. Most of the literature in economics has focused on the effects of these prescription drug monitoring programs, and there's reasonably strong evidence that PDMPs are associated with declines in opioid prescribing and with declines in drug treatment admissions, so better monitoring of where the pills are going does appear to be effective. There's also some evidence of policy heterogeneity there, though. Dobble Dave and colleagues find that the average state prescription drug monitoring program doesn't do too much to reduce drug-related addiction, but sort of the tougher types of laws, what he calls the mandatory access provisions, which require providers to query the state electronic database before prescribing can happen, those laws really have the big bite. So he's arguing that's the margin on which the previous studies have been sort of finding their effects. So there is almost nothing out there. So this is sort of going to your earlier question. There's almost nothing out there on naloxone access laws and Good Samaritan laws. Nada. So we're not building on anything. We are numero uno on this. What the little we know about naloxone access and Good Samaritan laws comes from case studies. So there's about 3 case studies I can describe. One was in Wilkes County, North Carolina. So I like the name of this intervention. It's called Project Lazarus. We're raising people from the dead. So doctors were trained to identify patients at risk of overdosing, and naloxone kits were made available to those at high risk if they watched a 20-minute educational video. And this was just sort of a before-after estimator found that opioid-related overdoses fell after the administration of the program. There have been several overdose education and naloxone distribution programs, the OEND programs, and there was a study of one of these that was implemented in a number of communities in Massachusetts. And they observed opioid-related mortality in some communities that got the intervention and other communities that didn't. It wasn't randomly assigned what communities got it and which communities didn't, but our laws aren't going to be randomized either, as I'll show you. So it was sort of tough. This was kind of a public healthy medical article, and it wasn't a top sort of journal article. So it's sort of a difference in difference, but there are no real standard errors. So I'm trying to be sort of careful. But it seemed difference in difference-y. Okay, and what they seem to find is that opioid-related overdose deaths fell more in communities that got this intervention as compared to those that didn't. There is also sort of been a descriptive study of the Washington state laws on naloxone access and Good Samaritan laws. So this gets a little at your question, Ryan, about information about how well people were sort of informed about the laws. And the answer was not too much initially. It took some time to sort of learn about the state statute. So that has some implications for the timing of when we think, if we're going to observe any effects of these laws on mortality, we might expect the bigger effects to happen later, after the passage of the law, given what we know from this qualitative study about how long it took people to learn about it. So there's been nothing about forward thinking about, you know, our so this has just been, are people, is anybody sort of aware of the law happening, not even sort of, are you aware and continue to be aware after you're gone, and that kind of thing. So I mean, being first, so this is an important sort of research lesson, right, for graduate students who are going to go on to kind of research careers. You know, if you can be first in something and be the first to sort of look at something, you can be forgiven a lot of other things about your paper. Like, perfect identification doesn't necessarily have to be there if you're first. So there are advantages to not being in sort of well-trod kind of literatures where you've got to really push hard to make what the contribution of your paper is. So this, what I'm presenting here today, has got lots of problems that lots of smart people in the room will talk about. But one of the nice things we get is to say, hey, we're the first to look at it, so we have to be better than anything out there, because there isn't anything out there. So we're going to look at the effects of these laws. We're going to look at whether these laws might have spillover effects to other substance use. We'll look at some differences across state laws to see if any types of naloxone access laws matter more. And then we'll look if there is any moral hazard effects on recreational use of prescription painkillers, where we've got some data. So our primary data source on mortality comes from the National Vital Statistics System's multiple cause of death mortality files. So we're essentially constructing state-by-year counts of opioid-related deaths. And so we're using the ICD-10 code, multiple cause of death codes, and these are the codes for opioid-related deaths. And then there has to be, for official CDC statistics, there has to also be some underlying cause of death. So we also restrict to having one of these underlying causes of death. If we don't impose that restriction, the results are the same, essentially, is what I'm going to show you. So first, I'm just going to show you trends in opioid deaths per 100,000 population over the last 15 years or so, and then show you the same trends, split the opioid mortality by mortality due to heroin and then non-heroin related opioid mortality. So that's largely the prescription painkillers. Yeah.
The CDC data,
Yeah.
you're just, the dependent variable is just all of the deaths in all those categories.
That's right. It's just a count.
What fraction of that, of the whole category, is the one that you focus on in the...
So the only...
above?
I'm sorry. So it's all of. So sorry. These are all of them. These are all classified as opioid. These are all classified as opioid. So it's all of them together.
Right. But homicide and suicide are not what you're interested in, right?
That's right. There just has to be some underlying cause of death associated with it. So just any of them. That's the way this. When the CDC publishes statistics on opioid-related deaths or deaths related to any substance use, they further restrict to having some underlying cause of death. The truth is, when you don't do this restriction, you're usually not talking about much of a difference in the count. But as I said, we've run everything without the additional CDC restriction, and it's the same.
Look, you have 44 unintentional 64 is suicide. 85 is homicide.
I'm sorry, those are codes.
Oh, right. What I
Yeah.
want to know is, how many of the total category are unintentional?
Yeah, that's a good question, and I can get it for you, but I don't know it.
But do I understand correctly that you run it once just with unintentional being deep?
No, I run it with everyone. Your account, you're a death if you died due to any of these opioid-related causes, and you have some underlying cause of death recorded for you. Any of those.
Wouldn't you want to limit it to the unintentional?
Not if we're following I mean, we could, but it's not standard for the way the CDC defines opioid-related mortality.
You have the data?
We have the data. Yeah. Yeah.
But I don't know
Yeah.
why.
We could. So here are the trends for opioid-related deaths between 1999 and 2014. So the blue line is all opioid-related mortality per 100,000 population. So it's more than tripling between 1999 and 2014. This is the crisis. The green line shows you trends in opioid mortality due to essentially prescription painkillers, the non-heroin related reasons. And the red line at the bottom shows you trends in heroin-related mortality. So what's happening? Around 2010, the mortality, even as total opioid mortality the rate is rising, we see a falling off or slight declining in opioid-related mortality due to prescription painkillers around 2010. Why is that happening? So there's been some discussion in the economics literature about why that's happening. How much of it is attributed to the crackdown on the pill mills, to prescription drug monitoring programs, but there's a really cool NBR working paper I urge you to take a look at, Rosalie Pakula and colleagues at RAND. Yeah, as I say, you can get it as an NBR paper now. I don't think it's been accepted yet. But there was a reformulation of OxyContin in 2010 that made it very difficult to take OxyContin, reduce it to a form where you could easily inject it. So it was trying to make it harder to abuse OxyContin in injectable form. So that's maybe what caused the fall off. And then what happens around the same time? The big jump in heroin-related mortality, that we might have seen some substitution of these people who couldn't use OxyContin anymore for their injectable high are now turning to heroin. Anyway, that's one story that they're offering in that NBER paper as to what's going on. But on net, opioid mortality is rising. The composition of deaths has changed slightly. Our data on the laws come from the Robert Wood Johnson Foundation, the Policy Surveillance Program. So what we're going to define to start as a naloxone access law is a state law that either grants criminal and civil immunity to non-medical professionals who administer naloxone, grants civil or criminal immunity to medical professionals who prescribe naloxone to patients, or allow medical professionals to issue third-party naloxone prescriptions. Again, all designed to increase the supply of naloxone. And our Good Samaritan law is, as we defined it before, basically providing immunity from prosecution. There are some weaker Good Samaritan laws that we really haven't looked at that say, like, as a mitigating factor at your sentencing, you can introduce that you were trying to save your buddy's life, but we're not going to call that as binding a law as holding you free of liability. So our methods are very straightforward, where it's a difference in difference style model. We'll be exploiting temporal and geographic variation in the passage of these laws. We're going to estimate both count models, Poisson models, and log rate models. So on the left-hand side, for instance, would be a count of opioid deaths in a given state and year. We're going to regress that on whether the state has enacted an naloxone access law in that year, whether they've enacted a Good Samaritan law. We'll control for state and year fixed effects, and then in the vector X we'll control for a set of state-specific time-varying controls, including other substance use-related policies, such as a prescription drug monitoring program, medical marijuana law, beer tax, cigarette taxes, all things that could affect the prices of complements and substitutes to opioids. We'll also include standard economic controls, an employment rate, per capita income, minimum wage to capture a low wage floor, and and some crime enforcement controls, per capita police officers. And then in our count models, we'll control for population. Okay? Here are the rollout of naloxone access laws. So here was New Mexico as numero uno in 2001.
Sorry, before you show us the rollout, can you just remind us for what period you have all of your data?
1999 to 2014.
2014.
That's right. That's right. So Ryan is alluding to a lot of our, well, I don't know if you're forecasting, but we're forecasting that a lot of the policy changes are happening in the latter part of the window as we look at the rollout. So New Mexico comes in 2001, then comes Connecticut, followed by California in 2008, Washington and Illinois in 2010, and then we really start coming in after 2012, after we get Massachusetts and Rhode Island. Now we get the full West Coast. We're starting to fill in the Eastern Seaboard, and by 2014, we get a lot more states adopting in the East, except for two, I must say, sort of two states where the opioid crisis has been among the highest. West Virginia and New Hampshire were biggies. Good Samaritan laws start even later, with New Mexico being the first to adopt, followed by Washington, New York, Connecticut, and we fill out here. And if I overlay the two maps to show you states that have adopted naloxone access laws and Good Samaritan laws, or just one or the other, it's here. So the blue states are those that have adopted both naloxone access laws and Good Samaritan laws. The darker green, only naloxone access laws, and the lighter green, the Good Samaritan laws. We do think we have enough independent variation in both of these laws to be able to identify their effects, particularly naloxone access laws. The Good Samaritan laws are even more bunched. But there definitely is a concern of us not having long post-treatment periods. So this is one of the costs of being first with a new law, right? There's not tons of data in the post-treatment period for a lot of states.
So, like in terms of your actual sample coverage, not just the policy coverage, like do you go to when, 2015?
14.
So you don't even have post-treatment for half of your.
Yes, that's right. For the 2000, that's right. We have in the year of enactment. That's right. That's right. I'm going to do something that's not in the paper, individually, for which we do have longer post-treatment data. But yeah, this is clearly sort of one of the costs of analyzing the effect of a new sort of hot law. It's one that's, well, actually, one of the other comments you could sort of get is, we don't like the comment. I think it's goofy, but we've gotten a comment, well, most states have now adopted these laws now, so what's the policy relevance sort of anymore? I don't know. Kind of like to know if they're effective or not, and whether they may, whether they make sense. So the making our case for identification is always in these models with a common trends assumption. So we'll look at pre-treatment trends in opioid deaths in the treatment and control states. Importantly, given how we think it may take time for people to get information about the law, we'll look at years after adoption of the law for the states for whom we've got data to be able to see are there bigger effects of naloxone access laws in the years after it's adopted. It is tough to come up with ideal drug-related falsification tests, right? Because a lot of drugs one could think about could be complements or substitutes to opioids. But we should generally expect second-order effects on potential complements and substitutes to be smaller than for opioid-related deaths. Though sometimes, given the multiple cause of death files, can be difficult to separate out deaths that might be due to, say, both cocaine and heroin, for example, which are, I don't say often, but are consumed together quite a bit in what's known as a speedball. All right. So here's some, give you a sense of the magnitudes, the means. So on average, our average weighted mean for a state in the sample has about 680 opioid-related deaths. So as we look at regressions that are essentially going to show you percent changes in the dependent variable, you can think about that percent in count models, a mean of about 679 opioid deaths. Okay. By the way, these numbers will be a little bit different from what you see in the paper. There was, in response to a referee report, was a slight change in the definition of an opioid-related death. And so then we break it up by heroin and non-heroin related opioid deaths. And let me just give you sort of a comparison. How do those magnitudes look relative to alcohol related deaths? A lot smaller. Relative to cocaine related deaths, quite a bit bigger. All right, so here's our first set of results from our Poisson models of the relationship between naloxone access and Good Samaritan laws on opioid deaths. So what do we find? We find that naloxone access laws in column 1 controls for just state near fixed effects. Column 2 adds all our state-specific time-varying controls. One of the things we like about this is that the point estimates remain about the same, suggesting that the policy is enacted orthogonally to at least the set of observable controls that we have. So we find that naloxone access laws are associated with about a 9 to 10% reduction in opioid-related mortality. For Good Samaritan laws, we find effects that are of comparable magnitude, but are less precisely estimated and hence not statistically distinguishable from zero, but we're not going to sort of jump off a cliff and say there's definitely no Good Samaritan law effect. Because, as I said, the naloxone access laws are estimated much more precisely. Yeah.
So you have quite a few in your states in your sample where they get both treatments. So have you looked at any potential complementarity between different treatments?
I do. Let me get right to. Yeah, I will. This is the result on the log rate model, slightly larger magnitudes, but again, a very sort of similar pattern of results. So I think my maps draw also people to the overlay map draws people also to be thinking about interactions. So we've tried to see whether if a state interacted sort of both laws, does it matter? And the answer is no. But having both an naloxone and Good Samaritan law in effect isn't providing some extra bonus that's reducing mortality. Yeah.
In your table 3, you have a significant negative coefficient on the log of population. I was puzzled by that. But we don't ever describe it. And it's odd for one thing, that a higher population would be fewer deaths.
So it's going to be a state-specific trend. So I'd have to think. I agree. I recall when running that, it wasn't sort of my first-order thought what it should be, but it would be probably a small state-specific change, right, in the state population and how that's related to opioid-related deaths.
It occurred to me, states that are losing population, higher absolute number of deaths.
Yeah, that's right.
Well, if you think about places with states that are losing population, they're very different than the states that are gaining population. So this is probably not a causal relationship, but places where, like Michigan or West Virginia, where people are moving away, or may just...
It could be changing in all sorts of other ways.
A trend that's going along with, it could be economic decline or something else that you might be thinking.
Is driving it. No, that's good. That's a good point. So something we wanted to think about is how reasonable is a 10 to 15% decline in opioid-related mortality from a naloxone access law, for example. So one way we'll try to convince you that, I was almost titled this set of slides I was telling Ryan, like, this isn't nuts. So this is my evidence for my 10 to 15% magnitude not being nuts. So there have been some other policies, some studies that have looked at the effects of other policies on opioid-related mortality. So Patrick and colleagues find that prescription drug monitoring programs are associated with about a 20 to 30% reduction in opioid-related mortality. Backhuber and colleagues find that medical marijuana laws are associated with about a 25% reduction in opioid related mortality. That's very big, suggesting that marijuana and prescription painkillers in particular might be substitutes. And Bradford and Bradford actually have David Bradford and his daughter have a paper looking at the effects of medical marijuana laws on prescriptions for opioids among Medicaid Part D patients, if I'm remembering, Medicare Part D patients, if I'm remembering right, and find a similar kind of relationship. So we find so relative to these other policies, we think actually our magnitudes are more reasonable than that, but we still want to go further. So a 10 to 15% reduction in opioid-related deaths is about 65 to 100 fewer opioid deaths. So we really, what we really would like to know is how naloxone access laws affect the supply of naloxone provided by pharmacies and community organizations, and then understand how that increase in supply of naloxone is related to opioid-related mortality. So there is no state-specific naloxone supply data available over this window, but there is some evidence from a new American Journal of Public Health article that got proprietary data from big retail pharmacies on prescriptions of naloxone in the very sort of latter part of our period. And again, this is a relatively small part of the naloxone market. A lot of the naloxone is not coming from doctors' prescriptions. It's coming from local law enforcement, from emergency medical services, from community organizations. So keep in mind, this is a relatively small share of the supply, but I think the trend is at least somewhat useful. So this is naloxone prescriptions at retail pharmacies. This is quarterly data suggesting sort of around 2012 we start getting a slight rise. This is about between 1,000 and 2,000 prescriptions per year, and then really ratchets up around 2014, 2015, rising really dramatically. So, given some of this, how big of an effect should we expect? Like I said, the two missing pieces of the puzzle is the elasticity of opioid overdose deaths with respect to naloxone supply, and how naloxone supply affects overdoses. So here's some descriptive evidence from the OEND programs. So we find some studies have found that a 187% increase in the number of naloxone kits distributed by community-based organizations is associated with about a 160% increase in the number of reversals reported by these organizations. Another Chicago program found that an additional 10,000 vials of naloxone is associated with about 1,000 verified reversals of opioid overdoses. And another study found 50,000 additional persons given naloxone is associated with about 10,000 overdose reversals. So these are, again, high-risk sort of individuals that were given these prescriptions. So for NALs to reduce deaths by about 70, the estimates suggest we need about 350 to 700 new high-risk prescriptions or new people to get naloxone to generate reversals of that magnitude. All I'm saying is I don't think the magnitudes we're finding are nuts, given this evidence that we've got. But it does seem like the lagged policy effect should be bigger, given that what we know about information rollouts and how prescriptions are skyrocketing in the latter period. So one thing we want to do is look for policy endogeneity, see if there are any differences in leads of opioid deaths. Were they trending differently in states that later adopted these laws versus they didn't? And then see whether the effects are bigger years after the law. So here's our event study. It's a pretty nice pattern. Sort of prior to the adoption of the law, the estimates are 0. The confidence interval is around 0, and then the effects get much bigger in the years after adoption, suggesting that the laws have bigger effects later. But it's important to point out that these latter coefficients here are identified by a small set of early adopting states. Here are coefficients on leads and lags after we throw all the controls in. Again, the biggest effects in the 2+ years after the law gets adopted. Here's the pattern for Good Samaritan laws. Not quite as pretty. Seems to be declining prior to adoption and then maybe falling a little bit more after adoption. We wanted to see whether observables predicted adoption of these laws. The only thing we find that's related with the adoption of one of these types of laws is the adoption of the other, which suggests that it ought to be in there. But we find that these other observable characteristics add very little explanatory power to variation in the adoption of the law. Yeah.
Sorry, back to your point on that, the event study. Mm-hmm. You made the point that I was going to make, which is that you're identifying that last coefficient only off of the early adopters. Mm-hmm. Do you have the results for just running it on the early adopters to see if those dynamics still hold?
A little bit. Yeah. So that's what this is not in the paper, so it's not fair. We're just adding it. So this is exactly what we're looking at, early adopting NAL states. So Washington, California, Illinois, Connecticut, New Mexico, and then looking at early non-adopters as the synthetic controls. So here's California, for example. Okay, so we find that, so we do the same Donald and Lang kind of estimate that Stephanie actually presented last week, and find that the laws associated with about a 20 to 23% reduction in opioid-related deaths. So the dotted line is the synthetic California, made up of Pennsylvania, Delaware, Nevada, Wyoming, and that should be, it's not Alabama, it's Alaska. Again, these the donor states have to have not adopted the law at any point through, I think we said 2012 or 2013. We wanted to have a big enough pool of donor states.
And the coefficient that you report at the bottom, that's the average.
Yeah, that's the average effect. That's right, but you can see at least some sort of getting bigger. We don't have too much sort of for Washington going on yet. And actually, Washington's the least satisfying one because this is one state where they adopted both laws simultaneously in 2010. So this is sort of the joint effect of the laws.
Why doesn't this go to 2014? Is it just because the donor pool gets too big?
Yeah, that's right. But there's no reason this can't extend out to at least 2012. But our donor pool starts getting crazy about what you can match to the synthetic. This is the problem with lots of states adopting the law. Not a much smaller thing going on in Illinois, Connecticut, and New Mexico. That's really happening with a lag, if at all. Okay.
Does your opioid-related death data go to the sub-state level?
No.
So it's only at the aggregate state?
Yeah, that's right. That's right.
So, sorry, I mean, I know you do it for all the states, and I know this is kind of how it often works, but you're putting 100% weight on Nevada.
Yeah, so New Mexico is almost an impossible. I mean, we don't even have a pre-trend. We have two data points, sort of pre-treatment for Nevada. So this we've got like nothing. Yeah, that's right. So I mean, Washington has the limitation I described. California, Illinois, and Connecticut are my bigger take-homes of the three. Yeah. Now given that we only have about 5 or 10 minutes, let me get to what I think could be interesting. So this is one of our shots at kind of a falsification test. One of the ways we can, I said these are multiple cause of death files. One of the, so we can measure alcohol-related mortality, and we can measure alcohol-related mortality that also includes opioids as part of that underlying cause of death. So we can separate out, so we find that naloxone access laws and Good Samaritan laws have no effects on alcohol-related mortality. Maybe not surprising. The only reason you might expect an effect is if you thought alcohol was a complement or substitute for opioids. But then one of the nice things we can do is look at alcohol-related deaths that had nothing to do with opioids. So opioids were not part of that death. And then deaths that had both alcohol and opioids as part of that death. So we do find some evidence that naloxone access laws and Good Samaritan laws are negatively related to deaths due to both alcohol and opioids, but not due to just alcohol alone. So there's a few, yeah, go ahead.
Well, it seems like if you explain a reduction in opioid deaths, you should also explain a reduction in alcohol and opioid deaths.
No, that's precisely, yeah, we want to. Yes, that's right. So we want to find it here. This for me is the important result, that there's nothing here. So one of the concerns is maybe naloxone access laws are being enacted as all sorts of things are getting better, and reductions in mortality are happening for lots of different substances. This is one that the CDC makes it very easily to separate out whether the death was caused by both or just one and not the other. So finding a null effect here we think is sort of really nice as one placebo test that we can offer. It's not a perfect placebo test, right? Because still alcohol could be a complement or substitute for opioids, so there still theoretically could be an effect. We'd certainly expect it to be much smaller. It's a lot harder to separate out for these types of substances whether opioids are also part of the death. So we don't find any evidence that naloxone access laws are related to the likelihood of an overdose due to a psychostimulant, so this is like meth. Or benzos, deaths due to benzodiazepine, right? We do find some evidence that's associated with a decline in overdoses due to cocaine. So where we're sort of going with this, actually, I think one of my RA, Toshio, I think you just won the prize. We're trying to work to sort of separate out these cocaine-related deaths. We're not going to be able to identify cocaine-related deaths alone that didn't involve any other substance, the way the CDC codes these deaths. But we can for sure identify those cocaine-related deaths that don't involve opioids. So that's what we'd like to run as a second falsification placebo type test to see whether this effect that we're finding here is driven by, as we suspect, that this is driven by deaths due to both cocaine and opioids. Okay. So I'll close with the what provisions matter most of the types of laws that Brandy was asking about. Well, actually, I'll put the moral hazard table up real quick after this. So the Good Samaritan laws, there isn't much heterogeneity in Good Samaritan laws. There's something for whether it extends to drug paraphernalia and for parole and probation violations. We didn't find anything that none of those specific provisions had consistent effects or mattered. We looked at standing orders so this was standing orders that pharmacists could offer for naloxone. We didn't find much consistent evidence that that mattered. We did look at 11 states that adopted NALs that removed criminal liability for possession of naloxone without a prescription specifically. And 11 states adopted this. We thought this might be a particularly important type of law that could get naloxone in the hands of people who are closest to those who are potentially overdosing. And that's what we found. We found that naloxone access laws that include this provision that remove criminal liability for possession from laypersons did have sort of an added bump on. So here's the main effect from naloxone access laws. So this is sort of the added bump, the added reduction in opioid-related mortality that comes from this specific provision of the law. So this is the type of law that we think mattered most, and the event study looked pretty nice. So we looked at data from the National Survey of Drug Use and Health. They asked questions about whether you've ever used prescription pain relievers for non-medical use, essentially recreational use of your Percocet, your Oxycontin, that kind of thing. We don't find any evidence at all of moral hazard, with the caveat of how precise are these estimates. So the dependent variable in these regressions is the log of the rate. This is the unlogged percentage of recreational use. So what we can rule out in terms of sized moral hazard effects, we can rule out about a 10 to 20% increase in recreational use of prescription pain relievers due to naloxone access laws. How sad, it's not completely satisfying, but for some of the key groups where we see over the biggest rates of opioid overdoses, ages 18 to 25, that's where we're closest to being able to rule out increases of more than about 10%. Okay? So there could be moral hazard. It's not bigger than a 10% increase in use of these substances. So to conclude, this is the very first study that's looked at the effects of naloxone access and Good Samaritan laws on opioid-related mortality, and we do find some evidence that they are effective, particularly naloxone access laws, in reducing opioid mortality. The future of naloxone is interesting. The price of a dose of naloxone is skyrocketing. It's risen from $1 a dose to more than $15 a dose in these self-injectable types of naloxone, which might imagine the biggest bang, potentially the biggest bang for one's buck. They're talking about prices rising as high as hundreds of dollars per dose. And so there's some discussion about why this is happening. Is it rising demand for naloxone? Is it collusion from a very few pharmaceutical companies that are producing it? But the days of local community health organizations providing naloxone for free to high-risk communities may be winding down as these prices rise. But this discussion of the opioid crisis ain't going anywhere on the public policy stage right now for some time. So it's going to be interesting to see what remedies policymakers come up with and who the new drug czar will be. All right, thank you all for coming out. Sorry about the being late. Yes, sorry, last question.
Now they're talking about funding the opioid reduction, opioid distribution throughout the country. Now they are talking in terms of $8 or $10 billion. So from your analysis, are you suggesting that reduction in the death due to opioid use 15% or 60,000 or something like that?
Well, I'm sorry, you said the estimating the cost of...
Yeah, I would like you to comment on it. Now they are allocating $8 billion, I think. To
fighting the opioid crisis?
Yeah.
I'd have to, before I want to comment on it, I want to see sort of exactly what they have in mind for what they're, maybe as part of the national emergency announcement, we'll get sort of more details on exactly what they're planning. I mean, in terms of the crackdown on the pill mills, there's no doubt that certain types of prescription drug monitoring programs have been found to be very effective at reducing addiction. So I haven't done sort of the welfare sort of analysis of the cost of implementing the state electronic databases versus the benefits of the reduction in addiction to intelligently sort of comment on it. I do know that naloxone, even with I think current prices, is still likely to pass most cost-benefit analyses of an effective, relatively low-cost intervention. With the one caveat that the moral hazard story is an important one. Policymakers are worried about it. Our results are reassuring, but certainly not this positive, given the precision of the estimates we've been able to find. So I'm not so comfortable yet. I'd have to see more of the details on what they're planning to do with that $8 billion initiative. Naloxone seems like a good low-cost intervention to me. Else? Thank you all for coming out. Please feel free to grab some more food on your way out the door, and sign the sheet if you have.